This introduction. We're going to introduce our first distinguished speaker, Dr. Khalid Bamakharama, who is a consultant gastroenterologist and hepatologist with over a decade of experience specializing in advanced interventional endoscopy. He's associate professor at Dubai Medical College. He combines clinical roots at Rashid Hospital and Sulaiman Al Habib in Dubai. His expertise spans therapeutic endoscopy for complex gastrointestinal and hepatobiliary disorders, contributing to medical education and advancing minimally invasive techniques in the UAE. Dr. Khalid, the floor is yours.
Assalamu alaikum. I'd like first of all to thank Dr. Abid Al-Lahabi and the organizing committee for this opportunity. Really very happy to be here and to participate. And I'd like to welcome Dr. Reddy. Dr. Reddy is my mentor, and I learned a lot from him in India with ERCP and advanced endoscopy. Okay, so tips and tricks in difficult ERCP cannulations. So I'm going to start with this case. This is a 45-year-old male with obstructive jaundice and cholangitis secondary to ambulatory adenocarcinoma. So I started doing ERCP with the standard cannulations. And you can see there is ulcerations in the ampulla. And once you see ulceration in the ampulla, this is most likely adenocarcinoma. So I failed with the standard cannulation. So what will be the next for these patients? So I don't have any disclosure, and this is my objectives. What is difficult biliary cannulations? And what are the factors contributing to difficult cannulations? And we are going to discuss the standard cannulation technique and to review the advanced cannulations, and we will speak about tips and tricks to maximize the success rate of cannulations. So difficult biliary cannulations. Cannulation is essential in ERCP. No cannulations means no ERCP, full stop. Even in the hands of the experienced endoscopist, failure of biliary cannulation can be up to 15%. And prolonged attempt is associated with higher risk of complication like post-ERCP pancreatitis, bleeding, and delayed therapy. So just let us review the anatomy of the ampulla. You can see the vertical trajections of the common bile duct and the horizontal trajections of the pancreatic duct, and both of them, they join together to open in the second part of the duodenum. But keep in your mind that 15% they can have separate opening. So this is one thing that you need to check upfront before embarking for cannulations. So you need to handle the ampulla and the papilla like a baby. First of all, position is very critical and very important, and you need to come a little bit down to the papilla in order to have the directions of your cannulations wires straightforward. And the first optimal point of first contact of biliary cannulation is very important. For the biliary, first touch is in the left upper quadrant, while in the pancreatic duct, you need to go to the 3 o'clock positions. So the first touch is really very important, because once you push your wire and sphincterotomy in one of the ducts, the sequence of going to that duct is very high because you made kind of dilatations. So the first touch is really very critical, and we'll see the common. So the axis of biliary axis is very important. You can see that the biliary directions is to some extent parallel to the duodenum, while in the pancreatic duct is horizontal to the wall of the duodenum. So maneuver facilitates selective biliary cannulation. Always we go with the short position of the scope because it gives you better movement of your wheels, and you can do all the maneuvers in a better way. But sometimes you need to go with long positions. Long positions sometimes will give you a better position for the papilla, a more stable positions sometimes in some cases, especially in distal located major papilla. So keep in your mind that 80% of the papilla in the second part of the duodenum, but 20% they will be in deep second part or the third part of the duodenum. And this is one of the challenging cases that you can see it. So this is one of the patients that he failed ERCP in other facility. So he came with us. You can see the long portions of the duodenum. The failure was because the papilla was in the almost third part of the duodenum. So this is my positions, long position. You can see that was Mersey syndrome. And once you cannulate it and you put your instrumentations, so you can, subsequently, you can shorten the long position to better position in order to put your stent, cholangioscope, like this case, whatever you want. So keep the papilla straight, engage the papilla orifice with few millimeter of the sphincterotomes. No need to push it all the way. Shallow insertion of the sphincterotomy, and then tip up and down, and then by your guide wire, you will be able to cannulate. Standard cannulation, we have the guide wire and we have the contrast assisted. And you can see that the guide wire assisted cannulations has the higher success and the lower pancreatitis. So that's why we go always nowadays with the wire guide cannulation, because it is less traumatic, avoid contrast injections to the pancreatic duct, high rate of biliary cannulations, and lower rate of post-ERCP pancreatitis. So difficult biliary cannulations, the ESG said that duration more than 5 attempts or more than 5 minutes, but the international consensus came with, they extended up to 10 minutes with 5 attempts and failure to access to the major papilla. So what are the factors that help you in difficult cannulations? What are the factors contribute to the difficult cannulation? We have patient factor, endoscopy experience, staff and technician are really very important. You have trained technicians, and sometimes equipment play sometimes role. So patient factors, you have the altered anatomy and variations in the papilla, like Barrett-Thue or Rowan-Y gastrojejunostomy. And we have different types of difficulties, like small papilla, diverticular, hidden papilla, tortuous, depositions, and tumor infiltration with adenocarcinoma. Sharpie papilla is one of the difficult because of the floppy papilla, and really, whenever you try to engage your sphincterotomy, it's really very floppy and very difficult. Keep in your mind that a small papilla, you can see that these are the types of papilla: normal papilla, small, protruding or pendulous, and then we have the crescent or ridges. You can see that the most difficult is the small and the protruding, which has the highest difficulty rate of biliary cannulations. So maneuver that facilitates selective biliary cannulation, we have the pre-cut pancreatic duct assisted, we have the double guide wire, or we have the transpancreatic sphincterotomy, or you can put pancreatic duct guide wire, stent, and then you do pre-cut assisted, and we have the percutaneous rendezvous, and we have the EUS assisted cannulations. So I'm going to focus on the pre-cut techniques: pre-cut papillotomy, needle knife, pre-cut fistulotomy, transpancreatic, and pre-cut over pancreatic ducts. So very important to see the anatomy of the papilla. So when you will do the sphincterotomy for this case, you need to know the directions and the depth of the cutting. So once you cannulate it, you will go from this opening, the opening, up to this seat, this part. So this is the direction of your standard sphincterotomy. So when you will come to the pre-cut, you need to respect these boundaries. So this is the pre-cut papillotomy. You will start from the opening, and you will go upward to go to the common bile ducts. And once you go to the common bile duct, you continue with the sphincterotomy for the rest of the sphincterotomy. Now, fistulotomy, again, you will start above 2 mm, above the ampulla, and then again, you need to respect the boundaries and to go up or down to cannulate the common bile ducts. So it's very important to respect the boundaries of the standard sphincterotomy, the pathway, the length, and the depth when you are doing the pre-cuts. So double guide wire is one of the way to take your patient if unintentional pancreatic duct cannulation happen. So the wire left in the pancreatic duct, and then you will take another wire, and you will try to. So the benefit of the double guide wire, it gives you kind of landmark, stabilize the papilla and it anchor it, straighten the duodenal portions, especially if it is S-shaped or zigzag-shaped, and then prevent the repetitive pancreatic cannulations. So this is the way. And the second type of the cannulation is the transpancreatic sphincterotomy, septotomy, or GOV procedures that came in 1995 by GOV. So the principle of this is to, once your guide wire went to the pancreas, you need to do the sphincterotomy to the directions of the common bile ducts. And this is the way you can see, once you cannulated the pancreatic duct, you will go to the, you will do the cutting in the 11 o'clock, and no need to cut it too much, 3 to 4, 5 mm is enough, and that will give you the success for the cannulation. So this is one of our patients. I failed the standard cannulation, so I'm doing the transpancreatic sphincterotomy. You can see I'm going to the directions of the CBD, which is at 11 o'clock, and then you can see 3 to 4 mm is enough sometimes. No need to continue deroofing the CBD sphincters. So you can see that there is some bile coming out now. And then after that, you can see very important to put the pancreatic duct after doing the transpancreatic sphincterotomy. And then after that, just putting the sphincterotome and pushing the guide wire, and most of the time you will be going to the common bile ducts. And then after that, you will continue your standard sphincterotomy as the usual way. And then this is the stone extraction for the same patients. So now, needle knife technique is another way. If you didn't went to the pancreatic duct, there is two approaches using the needle knife. You can have the needle knife papillotomy, or and then for this case, incision starting from the papilla and extending upward until you enter to the common bile duct. And the needle knife fistulotomy, incision started above the papilla, and in order to gain the access to the common bile duct. Now, very important to see the principles of the needle knife. So no need to keep your needle very long. So 2 to 3 mm is enough. And very important to go step by step, 2 mm every time in order to gain the common bile ducts. No need to do a very long, because your aim is to see the common bile duct where the bile will come in, and then after that you will continue with the standard sphincterotomy. Do not puncture or cut anywhere that you are not sure about it. Needle must be free and soft. Do not apply pressure to the duodenal wall in order to reduce the risk of complications. Usually better to use the upward and the elevator. Don't use the elevator. Better to use the scope maneuver and the wheels. Look for the, once you did the cutting, you need to see the bile and the orifice, and then just with probing the guide wires, you will be able to go. So this is one of our patients, again, 85 years old with cholangitis. You can see I'm doing fistulotomy, same 2 mm, and then going upward above the papilla, you can see pus started coming. So once the pus come, no need to continue your pre-cut. Just take the sphincterotome and push your sphincterotome and put your guide wire. And this is another example of pre-cut papillotomy. You will start from the opening, extending upward. Okay, so this is one of the really very difficult cases. And cutting again and trying to go. And unfortunately, I couldn't go the same day. After 2 days, I tried to go inside, and then I was able to cannulate it. And you can see, because of the stone, that it was cemented in the distal CBD, that was making the cannulation. The first attempt was very difficult. This is another example of the transpancreatic, pre-cut with the pancreatic duct insertions. The pancreatic duct will give you kind of preventions of the of pancreatitis. Not only this, but also you will be away from the pancreatic duct orifice. Another example
2 minutes,
of
doctor. 2
sorry?
minutes. Okay. You have 2 minutes.
Okay, so this is again pre-cut. You can see cutting. And then after pre-cut, you can see the cannulations. And this is 18 years old who came with obstructive jaundice. And you can see after cutting, continuing with the standard cannulations. So what is the best? Where are we? This is the meta-analysis comparing the different type. You can see the guide wire versus tips, transpancreatic sphincterotomy. You can see transpancreatic is better for cannulations. And needle knife papillotomy versus transpancreatic, again, transpancreatic is better. And you can see needle knife fistulotomy versus transpancreatic to some extent, both of them the same, but transpancreatic is slightly better. In terms of the complication, transpancreatic pancreatitis is the same with the guide wires and the needle knife, but fistulotomy is lesser in terms of the pancreatitis. In terms of the bleeding, all of them are equal. And this is another meta-analysis that they came 2 years back, comparing all different types of the these advanced techniques. And you can see that the transpancreatic sphincterotomy was the best among the other in terms of the double guide wire or the rest of the cannulations. Preambulary diverticum is another very important challenge. 4 types. We have the inner type that the duct was when it is inside the diverticle. So this is one of the cases. You can see that it was very difficult to see the papilla, and then I went with my gastroscope to see the ampulla, and then it was in the inner part of the diverticles. So what I did is I put a clip in order to pull the inner part of the rim, and then subsequently you can see the papilla now was obvious, and then we continue the cannulations in the standard way. Ambulatory carcinoma is another issues. You need to go probing the guide wires. In majority of cases, you will be able to cannulate it, but sometimes it's very difficult, like this case, first case, you can see I failed to cannulate the standard, and then I went for pre-cut. The proximal part was soft, and I was lucky to do the fistulotomy in the proximal part of the ampulla, and then I continued the cannulations and stented the patients, and the patient after that went for Whipple surgery. You can see there was a pus coming, and then after that we continued the sphincterotomy, and then we stented. So this is the final, and the patient went for surgery. So guide wire cannulations with the standard technique, if you failed with 5 attempts in 10 minutes, if there is no pancreatic guide wire insertions, you need to go with either fistulotomy or pre-cut, depend on the bulging of the papilla. If unintentionally the pancreatic duct, the wire went to the pancreatic duct, then you have 3 ways. You can do double guide wire, or you can do transpancreatic sphincterotomy, or you can put pancreatic duct and then go to pre-cuts. So to conclude, ladies and gentlemen, positions of the scope is very important. Deal with the papilla as a baby, understand the anatomy, respect the direction and the distance and depth. If you fail, change early, and don't stay just drilling the papilla with the same maneuvers. You need to change early. And call a colleague. Maybe that's not your day. Terminate the procedure. If you failed, bring the patient to another time or refer to another center. And remember, Albert Einstein, ego is one over the knowledge. Maybe that's not your day. Ask for help from a friend. Thank you.